Today I'm going to be talking about superbugs, ticking time bomb. So apparently I've chosen this topic because when we're in the midst of a pandemic, but we do have another slow moving pandemic that needs to be addressed, and that is antimicrobial resistance. And again, the month of November, usually in the month of November, we celebrate the World Antimicrobial Awareness Week. And it's a time to raise awareness about the use of antimicrobials, antimicrobial stewardship, and what we can do as individuals to also reduce the spread. And that was why I chose to give this talk at this time. So it's no news that we all know that antimicrobials has helped us in so many ways. It has revolutionized the way medicine is practiced. Obviously, looking back from where we came from, the pre-antibiotic era, where people would usually die from simple infections, from gunshot wounds, simple cuts. We can see that antimicrobials has really decreased the burden of infectious diseases. And in things like cancer therapy, bone transplants, and the rest of it, we know that people with immunocompromised situations would definitely have some underlying health issues that would require antimicrobials. So in general, we can say that antimicrobials have helped to reduce mortality and morbidity as well. And that is why, like the theme of this year's World Antimicrobial Awareness Week says, it says we should handle it with care. Otherwise, we might be heading towards a rock. And when we talk about antimicrobial resistance, what do we mean? I know most of us here have heard about it, so I hope I'm not preaching to the newly converted as well. But it's generally when bacteria no longer respond to the medicine that are meant to kill them. And as we can see from this slide, you can see this bacteria is already developed so much strength to be able to knock off the antibiotics. And this is what we talk about. This is what we mean when we say antimicrobial resistance. Now, over the years, information about antimicrobial resistance has increased. It's no news that this makes one of the headlines in most newspapers. You look at it that the miracle era of antibiotics is ending. We see that superbugs deadlier than cancer, and so many news about superbugs and antimicrobial resistance. But one thing we should bear in mind about this whole thing is that antimicrobial resistance is no respecter of borders. So we might just think, oh, this is a problem for low and middle income countries. It wouldn't get to us, it wouldn't get to Europe, it wouldn't get to Asia, that sort of thing. But yeah, we know that there's ease of spread of resistant genes. So there are things that carries this resistance around. And those things do not respect borders at all. So where have we come from and where are we going to? And why is this a problem? So basically looking at this slide, you would see from 1928. So 1928 when Alexander Fleming was able to come up with penicillin, and what do you see 12 years later in blue? Sorry, trying to get my mouse to it. And 12 years later, you're already seeing resistance to penicillin. And then what happened next? They developed the tetracyclines. And then over a couple of years, you see resistance to tetracyclines. And then even the very important ones, the one in green, carbapenem. So these are a class of drugs that would rely on in very serious situations. But what has happened? From 1993, we began to see an increase in resistance to carbapenems. And for the past 30 years, we now know that we haven't had a new class. So what has been happening all this while is reinventing the wheel, modifying the previous antimicrobials we have and the rest of it. So, and this is a very serious problem because if we haven't gotten a new antibiotic over these years, then it calls for a lot of concern and worry. It means we have to find ways of managing the ones we have. And this is the problem. We are actually dealing with a ticking time bomb. Ticking time bomb because pharmaceuticals are not as interested as producing new antimicrobials as they would with other therapeutic drugs like that for cancer and the rest. And that's because, before they even recoup their profits, from producing new antimicrobial, you just realize that this bacteria, these bugs again, are finding ways of developing resistance to the new classes of antimicrobials, which means it's not a profitable venture for most pharmaceuticals to go into. And what is driving this whole spread? What is driving this resistance? Obviously, in human population, in the animal population, in agriculture, we often use antimicrobials. And for animal production, for instance, antimicrobials or antibiotics can be used for prevention of diseases, for treatment of infections, or for growth promotions. We know that a lot of countries have done so well in ensuring that antimicrobials will not be used as growth promotion, but other countries have not done as well. And some farmers just think the more antimicrobials we incorporate in our feed, the bigger our beds, the more resilient they will be to infectious diseases, and the bigger the eggs and the more profits they will make. But obviously, this is not good for every one of us because these animals still share the same environment as humans, and the same goes for humans as well. When we request for antimicrobials for reasons that our body system can fight, when we're giving antimicrobials and we don't complete the course of the antimicrobials, and when we don't ensure infection prevention and control, obviously we share the same environment with other people. We could go to the hospital, spread the infections, and then it keeps going. And even from food, so we can get resistant bugs from eating food directly. And these are some of the drivers for antimicrobial resistance. Looking at what we will be facing in the near future if nothing is done, you can see from the map on the left that it is estimated that death from antimicrobial resistance alone will get up to about 4.1 million in Africa. So the bigger the circle, the bigger the deaths. So we can see in Asia and Africa that there's a lot of problem that needs to be addressed as well. And then on the right, you can see the deaths attributable to other cases or other conditions, and that's attributable to antimicrobial resistance. So if you see cancer alone, that's 8.2 million. So it's projected that deaths from antimicrobial resistance by the year 2050 will be 10 million. And that is over that of cancer. It exceeds death from cancer. It's going to exceed death from road traffic accidents, death from diabetes, death from diarrhea diseases. So it is a very serious problem that needs urgent attention. And as we travel from one continent to other, so we might look at those big cycles and say, oh, well, it doesn't bother me. But as we travel around the world with the ease of international food trade, animal movement, farming system, and the rest of it, the likelihood of passing these resistant genes also comes with it. So at the moment, we have a low estimate. We call it a low estimate because not everything is being reported, of 700,000 deaths. But we expect that this is not even correctly reported. What's the situation in England, in developing countries? We're being told that 1 in 3 patients in 1 in 3 patients in hospitals within England are on an antibiotic at any one time, and 1 in 3 individuals in England will take at least one course of antibiotic each year. So despite the fact that we're looking at that situation in the developing world, we also have a problem in developed countries. And who is prescribing this in the developed world? We have about 74% of this goes into general practice. So when we go to the GP and they give us the antibiotics, but we have others from hospital inpatients, from hospital outpatients, from dental practices and other community settings. In fact, there is this study that is looking at antimicrobial use in elderly homes and residences across the UK, and you'll be surprised what you'll find, because obviously you don't want these people to fall sick or get into complications. And then what's usually the solution? They just give them antimicrobials to help them. Yeah, so we've looked at the situation in developed world. What about in developing countries? Obviously, like many infectious diseases, like many problems that we know about, the highest burden of antimicrobial resistance will be in low and middle income countries. As we know, for instance, the COVID pandemic has exposed the vulnerabilities of our health systems in some developed countries, and even more in developing worlds. We can now see the weaker health systems. We can see the global inequalities in healthcare where people can't access healthcare. And all of this, is also helping to drive resistance around the world. So even as much as we talk, even though we talk a lot, we speak a lot about misuse and overuse of antimicrobials as a driver for antimicrobial resistance, we still have a lot of rural communities, a lot of rural environments that don't even have access to these antimicrobials. They lack the purchasing power to get the antimicrobials. And what happens if someone can't access antibiotics? It means the person would choose to either stay with the infectious disease, keep spreading it, the infection gets complicated to the point that a first-line antimicrobial would not work. They would now require a more expensive antimicrobial. And if there is no universal health coverage in that country, what would happen? The case becomes worse and probably eventually lead to death. So in most low and middle income countries, we see widespread of unhygienic conditions, poor sanitation that is driving this resistance, and poor infrastructure. And what is happening? Antibiotics has now been a source of quick fix. So people think, I don't have the money, I have to go out to work tomorrow, but I've got gastroenteritis, I've got diarrhea. Do I just sit here and let everyone in my family die? Or do I just pop in this pill into my tummy, feel better, and go off to work? Or you get to a hospital where sanitation is almost missing, where people have to do surgical procedures under very dirty environments, and people might not just have the option, but to give as much antimicrobials to prevent infection. And obviously we've talked about equality. So people just think this is a quick fix, but then we must remember that this thing that we refer to as a quick fix is actually leading us to a long-term problem and must be taken very seriously. So my work looks at salmonella. In my PhD research, I'm basically looking at the genomic analysis of antimicrobial resistant salmonella. And why have I chosen salmonella? Salmonella infections have been described as one of the most important foodborne pathogens. So we do know that in developing worlds, a lot of sanitation is being improved. So the incidences of salmonella will be a bit lower than you find in low and middle income countries. But then you still find it in areas where large scale commercial production, like you might buy a product from any of the stores and later they recall it for having salmonella. But the situation, however, is higher. It's worse in low and middle income countries. We have thousands of deaths from salmonella infections every year. Now, salmonella can be categorized into two salmonella infections. We have those that are human specific, and those ones are referred that cause typhoid fever. They are referred to as the typhoidal salmonella. And we have another group that are referred to as the non-typhoidal salmonella. Now, the group I'm dealing with are the non-typhoidal salmonella, and it's been estimated that this group would cause usually cause almost 160,000 deaths per year. Again, this is an underestimation because a lot of the cases will go underreported. And in most low and middle income countries, we're also seeing invasive salmonella. So you would ask me, why are you concerned? Why is it a problem? Obviously, it's a self-limiting problem for people who are not immunocompromised. So for healthy individuals, one might get salmonella and recover within a few days. But we have a small percentage of the salmonella infections that go on to cause more serious problems in people, meningitis in children. In some cases, you get gastrointestinal perforations and the rest of it. But the other problem is that in animals, the animals will keep shedding this bacteria even though they don't show any signs. And obviously for many infections, we know that the highest burden will be in the elderly and in the children. So it is something that demands attention. What's the justification for my study? So now, if we think salmonella is a big problem, right, we have to be able to understand what is in circulation in a particular environment before we can begin to develop solutions or say what strategies we'll put in place to reduce that problem. And for salmonella infections, for the bacterium salmonella, like other bacteria, the sort of serotypes and the strains that circulate in one area is different. So what we will find in Europe will be different from what we'll find in sub-Saharan Africa, could be different from what we'll find in Asia and that sort of thing. And then recently, not just in the near, very recent, but we're seeing studies that are reporting multi-drug resistant salmonella. So multi-drug resistance is where a salmonella bacteria develops resistance to more than 3 antimicrobials. So if we want to help physicians to do proper treatment, we have to take into account what is in circulation in that environment to be able to, and also for policymakers as well. So if you want to say, the government wants to say, we find a lot of people who are developing resistance to this, who are dying from this infection, what is the evidence that they need to be able to change the policy? So that's what my research aims to address. So basically, I'm looking at shared salmonella strains between people and animals, and to see if there are any patterns of resistance between people and animals as well. So to do this work, I collect samples from farms in Nigeria, collect samples from hospitals, and I also have some environmental samples. Now I'm going to run through the process, and this is not really important, but I just want to show you that when I collect the samples, I take them through this process. I do some lab enrichment, and then on the right, you see, we also do some molecular work, the PCR work, and we tend to look out for a particular gene. So where you see the 284 base pairs is where we're looking for a particular A gene that is common for all salmonella. So when we find it, we'll find out, oh, this could be a virulence gene, and it shows that we probably have salmonella there. But yeah, don't worry about this. The most important part, would I say most important, because they tend to complement themselves, culture-based technique, PCR, and whole genome sequencing. We're seeing whole genome sequencing as a big success for studying bacterial genomics and for infectious disease control, because it can tell us where, it can track the source of any infection, and it can tell us where that infection is coming from. It can give us the link between that isolate and other isolates in a variety of environments and a variety of sources. And this is one of the things my research aims to look at. So I obviously collected a lot of strains, but these are 179 that showed to be salmonella, and this 179 are pooled isolates. So what you see as ST and the sequence type. So for ST198, for instance, it shows that this sequence type is in poultry, and ST11. But I was looking, I set out to see if there is any relationship between the sequence type in humans and animals. So if you look at this ST11 in light blue here, this is the same one here. And if you come to the right and you look at the same one here, you would see that it's found in poultry and it's found in humans. So this also, when you're looking at it just very quickly, it gives you an indication that some of the salmonella isolates that we find that we got from our work actually has an evidence of transmission between people and animals. So this other slide shows you the serovas. So if you talk about Salmonella typhi or Salmonella Kentucky or Salmonella Orion, it just tells you what particular Salmonella serovas you have in circulation. And you can imagine for just this 179 isolates we collected, we already have 41 sequence types and 32 serovas. What's the implication of this? Sometimes the therapy that would work for a particular serova might not work for another serova. So you can imagine drawing up or using just one medication, say you're using amoxicillin or whatever antimicrobial, to target all the salmonella infections. There will be mixed infections because some of them might not respond in the same way. Some of them might carry resistant genes that we do not know about. And this is one of the importance of studying what is in a particular location. Now I picked that ST11 strain, which was found in just humans and animals, and I tried to explore it further. So what you will see on this NJ tree is to see how distantly located that from human is from that of poultry. You know, you can see that the human ones are closely related. They share a cluster, and there's a poultry one which is also found in this cluster. It also goes a long way to show us the interaction between humans and animals. So what has this genomics shown us here? What have we gotten from the genomic study so far? We've seen the high-level genetic diversity of Salmonella circulating within the country and evidence of transmission between people and poultry. So now the next is to just give you a highlight of the resistant genes. So by the left here, this is a phylogenetic tree. It just tells you on the left every Salmonella strain you have gotten and their serovas and their sequence types like we've learned this evening or we know this evening. And then on the right, wherever you see a darker box, wherever you see a dark colored box, it gives you an indication that there is a resistant gene in that area. It tells you that there is a resistant gene there. It tells you there's a resistant gene in that location. So I've just picked out this one that is circled ST11 and ST216. ST11 is enteritidis and ST216 is isangi. So basically, where you see the dark colors gives you an indication of resistant genes, and that's what I want you to see. So what you realize here is that some of the strains have shown resistance to more than 5 classes of antimicrobial agents, which is really problematic. So if an isolate is showing resistance to more antimicrobials, then you can imagine what other effective antimicrobials would we have to get rid of this. So this goes for this and this. And then I picked up another strain here. So what you have below here, I'm not going to go into all of these details, but what you have here basically are the genes. So we have genes for aminoglycoside resistance, we have genes for beta-lactam resistance, and all of this, trimethylprim and sulfonamide, and all of these are classes of antimicrobials as well. So the same for another serum, where you see the dark colored boxes, you find resistant genes as well. So one other thing that happens with antimicrobial resistance is that we have things called mobile genetic elements. And these mobile genetic elements are classified as jumping genes. So it means that this plasmids or mobile genetic elements can move from one organism to the other. So I also looked to find what plasmids I have in my isolates. And I came up with this. So for the ST11, the sequence type 11, we've already looked at. We found some of these plasmids, which means that if this plasmids, the implication of this, all these names that I'm not going to go into details about, is that if any of those plasmids, which is found in this Salmonella cerevisiae, shares the same environment with another bacteria, say E. coli, there is the possibility that the plasmid can move from Salmonella to the E. coli. So you can imagine for the guts, or for the gastrointestinal system, where you have different bacteria organisms sharing the same environment. So even if that other bacteria does not show resistance, the possibility of acquiring a resistant gene increases as they share the same environment with other bugs. So how does this fit into the bigger Nigeria picture? We went further to look at other publicly available data, and I collected this data and analyzed them in this phylogenetic tree you're looking at. So simply put, what you see here is the same non-typhoidal Salmonella strains. So the different colors here shows you the sources. So basically where you see bovine, where you see grain has been collected from camels, where you see fish has been collected from fish, and that sort of thing. So if you look at, for instance, this cluster here, this cluster down here, the cluster to the right, far right end, you see that a lot of it's being collected from diverse sources, and see how closely related they are, even though they are from different animals or from different sources, including human. You can see how closely related they are. And that also shows us the ease with which transmission can spread as long as we share the same environment. And that's the importance of One Health, why we have to address issues and diseases in a One Health approach. Again, so these strains were collected from these ST11 strains. I went further to look at the strains that were collected from across Africa. And what you can see in red here were those from a bit of West Africa, where Nigeria also lies. You can see to the right that, so these are countries that some of them don't even share borders with each other. But you can see how closely related, how clustered the strains from these regions are. So in the right, you see, I've just picked the one in red and I've expanded it here to the right. So you can see Mali, Senegal, Nigeria, Burkina Faso, and Malawi sharing all of the strains. So this again just shows us the resistant genes on those ST11. So what I basically picked out here is the human clade. I'm going to talk about it more. But one thing that is common with this human clade is that they've shown resistance to the beta-lactams, chloramphenicol. And despite the fact, so this is, I've just zoomed into that same circle there. So despite the fact that these strains were collected across different years, so you can see some that were collected in 1999, 1985, 2011, 2005, they still shared the same cluster. They still clustered together as a result of the antimicrobial resistant patterns that they share. Yeah, I'll just quickly for sake of time. So we can see that genomics has helped us to see the sort of antimicrobial resistant genes that are circulating in populations. And it's also helping us to shape the population of non-typhoidal salmonella. It is telling us what is going on in circulation across space and time. And it gives us an evidence by empiric treatments and helps decision makers to decide on what therapy to use. And we can also see that using genomics, we can monitor the spread of mobile genetic elements. Again, we've seen the antimicrobial use in human population, animal production, and agriculture is an important driver for resistant genes. So we have to have a knowledge of what is in circulation as well. But what can we do? We've seen all the problems. What can we do as a people? We can ensure in our hospitals, within our own households, wherever we are, that would ensure infection prevention and control. And these are things like simple things like water and sanitation, hygiene, so as to reduce the spread of resistant organisms. We can also improve appropriate antibiotic use. We don't have to demand for antimicrobials when we don't need it. We know that oftentimes, we're not saying antimicrobials are not good. They are basically good. And when it's important, we need to use them, otherwise we keep spreading infections. And we also have to increase the coverage of vaccines. Now we need new therapeutics, we need new diagnostic tests, because one of the things that is helping to drive resistance is when doctors cannot make a decision because the diagnostic test will take 2 or 3 days. What do they do within those 2 or 3 days? They either give a broad range microbial antibiotic, or they wait. So we need faster diagnostic techniques to help us make better decisions. And what can you do as a person? Obviously, this is a very brief talk, but you can sign up to become an antibiotic guardian. You don't have to be studying biology or be in a science field to do that. Anyone can sign up to be an antibiotic guardian, and you can do that through this website here. There's a lot more information that we can get from this website as well. So we've seen that AMR, we have a pandemic right now, but AMR is a slow-moving pandemic and a ticking time bomb. It respects no borders and requires national, regional, and global collaboration. We've also seen the place of mobile genetic elements and genomics. So I'm going to just thank my founders and happy to take any questions you have. Thank you.